So what we're going to do is take this image of the heart and superimpose it on the image of the chest wall and determine the outline of the heart in that way. So that's what we have on this picture. We've created this outline of the heart. So let's start off with being fairly specific in identifying where this outline is. The right upper corner of the outline, the right upper corner of the heart, is at the third costal cartilage on the right side, about 1/2 inch away from the sternum. The right lower corner is at about the 6th costal cartilage on the right, also about 1/2 inch away from the sternum. The left upper corner is at the 2nd costal cartilage on the left, about 1/2 inch away from the sternum. And then lastly, the lower left corner, which is what we call the apex, is in the 5th intercostal space at about the midclavicular line, which corresponds to being about 3.5 inches away from the sternum. So when we connect those 4 corners with a dotted line, we've now pretty well characterized the perimeter of the heart, the outline of the heart. So we know that a penetrating wound through the anterior chest wall through a region within this perimeter would likely injure the heart. If it was outside of that perimeter, then it would injure the lung, and we would use our knowledge of the surface anatomy of the lung to determine which lobe of the lung. But now we have to get a little bit more specific, because certainly simply knowing that the heart is here is not going to be sufficient. We're going to want to know which part of the heart is in which part of this outline. So we have to add some more information to this diagram. So let's imagine that we're looking right through the anterior chest wall, and we're looking at the anterior surface of the heart, and we can see those landmarks that are seen on the anterior surface of the heart. And let's add those in. So we'll start off with the coronary sulcus. So the coronary sulcus on the anterior chest wall, on the anterior heart wall, roughly parallels the right border of the sternum. The right border of the sternum. That's where the coronary sulcus would be. And it's useful for us to remember that the alternative name to coronary sulcus is atrioventricular sulcus. Those are synonymous terms, coronary sulcus and atrioventricular sulcus. And that's a useful name because that tells us precisely what the sulcus is. It is the groove or the sulcus that separates atrium from ventricle. So on one side of that line is going to be atrium, the other side is going to be ventricle. Since we know this is the right side of the patient, we can now infer that the right atrium is over here. And on the other side of that line, that's where the right ventricle would be. The other major landmark on the anterior wall of the heart is the interventricular sulcus. So let's put that in. The interventricular sulcus would be approximately there. And that name, interventricular sulcus, tells us that it is the groove or sulcus between the ventricles, interventricular, between the ventricles. So that means it's going to separate right ventricle from left ventricle. We've already established that this is the right ventricle here. So if we go to the other side of that line, that would have to be the left ventricle over here. Now, let's come back for a moment to this coronary sulcus. And remember that the reason it's called coronary sulcus is from the root for coronary, corona, meaning crown. It's the coronary sulcus because it circles the heart like a crown circles the head. So when we follow this coronary sulcus down to the bottom of the heart here, it doesn't end at this point. It encircles the heart. It goes behind the heart, runs up across the back wall of the heart, all the way to the left border, then comes back around the front again. So the coronary sulcus continues over here. So let's put that in. There's the coronary sulcus. And it's still atrioventricular, so that means it's separating atrium from ventricle. So we've already said that this is the left ventricle, so you go to the other side of that line, and that's going to be the left atrium. So now, by adding those two landmarks, the surface position of the coronary sulcus and the surface position of the interventricular sulcus, we can now divide up this anterior wall perimeter of the heart into its chambers. And we see that the right atrium is forming the entire right border of the heart. We see that the right ventricle forms much of the anterior surface of the heart, with a good bit of the right ventricle being behind the sternum, but it also projects to the left of the sternum. We see that the left ventricle forms most of the left border of the heart, except for the upper part of the left border, which is the left atrium. So from this anterior view of the chest wall, what we're saying is we can see a lot of the right atrium, an awful lot of the right ventricle, a lot of the left ventricle, but just this little bit of the left atrium. So that implies that the left atrium must be someplace out of view primarily, and indeed it is on the posterior side of the heart. So the entire posterior wall of the heart is made up of the left atrium. So those are a few major landmarks that are very important for us to know in order to interpret imaging of the chest, whether it be radiologic imaging, echocardiographic imaging, also for reading electrocardiograms, doing physical exams. We need to know what's forming the boundaries, the borders, and the surfaces of the heart. So just to review that, we're saying the right border of the heart is entirely right atrium. The anterior wall of the heart is mostly right ventricle. The left border of the heart is mostly left ventricle. The posterior wall of the heart is entirely left atrium. And then lastly, the inferior wall, the surface that is sitting on the diaphragm, is primarily left ventricle. Those are very important landmarks. So if we now compare what we just did on that outline to the heart itself, what we see is, sure enough, we see the right border of the heart is entirely right atrium. All of this anterior wall of the heart is right ventricle. We see that the left border of the heart is mostly left ventricle, except for the very upper part of the left border, where we see a little bit of the left atrium, the auricular appendage, wrapping around onto the front, but most of the left atrium is on the back of the heart behind the screen. The other important point that I want to make on this slide, and we'll come back to it in a few moments, is to take note of the fact that the two outflow vessels from the heart, the ascending aorta and the pulmonary trunk, are both emerging from the anterior wall of the heart. And more specifically, we see that the ascending aorta is on the right and the pulmonary trunk is on the left. And that sometimes can be confusing because we know that the aorta comes from the left ventricle, but nonetheless we see it on the right. The pulmonary trunk comes from the right ventricle, but nonetheless we see it on the left. So we're going to have an explanation for why that is like that. And of course, it is an embryologic explanation, which we will come to when we take a look at the embryology of the heart. But again, to review the borders and surfaces of the heart and how we can apply that information, if we look at an anterior view of the chest, a frontal image of the chest, we can see the heart shadow here, and we said that the right border of the heart is going to be right atrium, and sure enough, that's what that is. We said that the left border of the heart is going to be left ventricle, and most of that left border is left ventricle, but we said the very upper part of the left border is left atrium. So that's what's over there. If we take a look at a lateral projection of the chest, this is anterior on your left and posterior on your right. So this is the anterior surface of the heart, and we said that that's going to be right ventricle. That's the posterior surface of the heart, and we said that would be left atrium. And this is the inferior or diaphragmatic surface of the heart, and we said that that would be left ventricle. So you can see how knowing those simple borders and surfaces are critical for reading chest films, and they will be similarly critical for reading CTs of the chest, which we'll do later on. So now let's continue to use this information about the surface projections of the heart to help us understand the auscultation points for the valve sounds. So on this slide, we see the 4 auscultation points relating to the valve closure sounds for each of the 4 valves. Now, what I really don't want us to do is to simply memorize the 4 auscultation points and hope that we'll remember it that way. It's far better if we understand why the auscultation points are where they are, and that way we don't have to memorize it, but it will also allow us then to apply that understanding to figuring out abnormal heart sounds, specifically valvular murmurs. So let's talk about normal valve sounds, and then we'll talk about abnormal valve sounds. So the normal valve sounds, the so-called S1 and S2, are the sounds generated by the closure of the valves. So the 2 AV valves, in other words, the valves between the atria and the ventricles, the tricuspid valve on the right and the mitral valve on the left, those valves close at the beginning of systole, and they open at the end of systole, at the beginning of diastole. The 2 outflow valves, the aortic valve and the pulmonic or pulmonary valve, they open at the beginning of systole and they close at the beginning of diastole. So the sounds are generated at the time of closure. So S1 marks the beginning of systole and S2 marks the beginning of diastole. So that's when you hear the sounds. Now what about where you hear those sounds? Why are the auscultation points where they are? And there's one general principle that we need to know that will explain this, and then there's one anatomical fact that we need to know. The principle is simply this. The sound generated by a valve is best heard not by placing the stethoscope directly over the valve, but rather by placing the stethoscope over the region downstream from the valve. In other words, where the blood flows to after passing through the valve. And that's where the sound generated by that valve will be heard best. That's the principle. The anatomical fact that we want to know is reflected, if we go back one slide to this lateral image of the chest, we can see that the heart is tilted forward in the chest so that the bottom of the heart is closer to the anterior chest wall, which means it's going to be closer to your stethoscope, which is on the anterior chest wall. So, if we know that fact and we know the general principle, we should be able to figure out the normal auscultation points. Let's start with the tricuspid valve, the normal S1 of the tricuspid valve, the closure of the tricuspid valve. We know that the tricuspid valve is between the right atrium and the right ventricle, which means the blood is flowing to the right ventricle. So we're going to hear that sound best by putting our stethoscope over the right ventricle. We've said that this region that I'm outlining here is the right ventricle. Well, we're certainly not going to put our stethoscope on the sternum. We don't want the bone in the way, so we're going to put it over an intercostal space to the left of the sternum. Why do we choose the 5th intercostal space? Because the heart is tilted forward, so that the bottom of the right ventricle is closer to the anterior wall, therefore closer to your stethoscope, so you'll hear it best here, near the bottom of the right ventricle. So that's why the tricuspid auscultation point is there. For the mitral valve, we know that the mitral valve is between left atrium and left ventricle. So the blood is flowing to the left ventricle. We know that the left border of the heart is left ventricle. And we know that the bottom of the left border, where the apex is closest to the anterior chest wall. So we're going to put our stethoscope near the apex, in other words, in the 5th intercostal space at the midclavicular line. So when we want to hear the tricuspid S1, we put it in the 5th intercostal, we put the stethoscope in the 5th intercostal space right up against the border of the sternum to be as far away from the left ventricle as we can get. And when we want to hear the mitral valve, we put it over the apex in the 5th intercostal space at the midclavicular line to be able to be as far away from the right ventricle as we can get. So both of those points are explained by the same principle. For the 2 outflow valves, the S2s that are generated by the outflow valves, we know that the aortic valve is going to be between the left ventricle and the ascending aorta. so the blood is flowing to the ascending aorta, so we want to put the stethoscope over the ascending aorta. And we've said that the ascending aorta exits the heart and goes up and to the right. So if we want to be above the heart and to the right, we go to the second intercostal space, just to the right of the sternal margin, and that's where we would hear the S2 generated by the aortic valve. For the pulmonary valve, it's between the right ventricle and the pulmonary trunk. The blood is flowing to the pulmonary trunk. We want to put our stethoscope over that. We know that goes up and to the left. So putting the stethoscope up and to the left in the second intercostal space to the left of the sternum would place us over the pulmonary trunk, and that's where we would best hear the pulmonic valve. So all four of those normal valve sounds, the auscultation points for them are determined by simply applying exactly the same principle over and over again, and that leads us to those 4 points. So now what about abnormal sounds, specifically murmurs, valvular murmurs, murmurs that are generated by abnormalities of the valves? First, we need to understand what a murmur is and what's causing a murmur. A murmur is the sound that is heard as a result of turbulent blood flow within the heart. So with regard to the valves, we're going to get turbulence when the blood is trying to pass through a constricted opening. When blood is passing through an opening that is of normal diameter, the flow is smooth or laminar and doesn't generate a sound. But when it passes through a constricted opening, it becomes turbulent, and it's that turbulence that we hear and call a murmur. So that leads us to the question of why would the opening be constricted or narrowed? And there could be 2 answers with regard to valves. It could mean that the valve doesn't open fully when it should be open, or it could mean that the valve doesn't close fully when it's closed. In either case, it will leave an opening that's constricted. Blood will be passing through that constricted opening and causing a murmur. So if we know when the valve is supposed to be open and we know when the valve is supposed to be closed, we'll be able to distinguish between murmurs caused by valves that don't open fully and murmurs caused by valves that don't close fully. So let's take a look at this chart here. With regard to the AV valves, the tricuspid valve and the mitral valve, we know that those valves are open during diastole to allow the ventricles to fill. So if when they are open, they don't open fully, we call that stenosis. If we have stenosis of an AV valve, we will hear that murmur during diastole because the valve is open during diastole. If when that valve should be closed, it doesn't close fully, and therefore it will leak, we call that insufficiency of the valve. And since the valve should be closed during systole, we would hear that as a systolic murmur. So with regard to the AV valves, stenosis of those valves will cause a diastolic murmur. That means a murmur heard during diastole. And insufficiency of those valves will be heard as a systolic murmur, a murmur heard during dystole. And then, of course, it's going to be just the opposite for the outflow valves, the pulmonic and aortic valves, because they are open in the opposite portions of the cycle. So since the outflow valves are open during systole, if they are constricted when they open, in other words, if they are stenotic, we'll hear a systolic murmur. And since those outflow valves should be closed during diastole, if they don't close fully, if they're insufficient and they leak, we will hear a diastolic murmur. So for the pulmonic and aortic valves, systolic murmurs indicate stenosis of the valve. Diastolic murmur indicates insufficiency or incompetence of the valve. So that deals with the issue of when we hear the murmur. Now we have to deal with the issue of where do we hear the murmur. Where do we hear the murmur best, actually? And that will lead us back to applying exactly the same principle as we did before. So if we look at this image, let's start off with the tricuspid valve, just as we did before. Let's say that the tricuspid valve has an insufficiency. There's an incompetency of the tricuspid valve. So that means when it should close, it doesn't close fully, which means that during systole, when it is closed, it leaks, which means that blood will go retrograde. There'll be backflow from the right ventricle back to the right atrium. That would be called regurgitation. So you'll have regurgitation during systole. It's passing through a constricted opening. That means it's going to cause a murmur. But now the direction of flow is toward the right atrium. That's what is downstream now. So you're going to put your stethoscope over the right atrium, which we know is on the right side of the sternum. Again, we'll go to the lowest part of the right atrium, which is the right fifth intercostal space. And so where you'll hear a tricuspid insufficiency or a tricuspid regurgitation will be in the right fifth intercostal space. Even though the normal tricuspid auscultation point is in the left fifth intercostal space, tricuspid insufficiency would be heard as a murmur during systole in the right fifth intercostal space because you're getting a reversal of blood flow, and therefore you have to change where you put your stethoscope. If, on the other hand, that valve was stenotic, then the direction of flow would be normal. You would hear that murmur during diastole when the valve is open, and you would hear that in the normal location for a tricuspid valve, the left fifth intercostal space. To use another example, let's think about the aortic valve, which is a much more common valve for valvular disease. If the aortic valve is stenotic, that means when it is open, it doesn't open fully. It's open during systole, so that aortic stenosis would result in a systolic murmur. The direction of flow is toward the ascending aorta. We know that means that we're going to put our stethoscope here in the right second intercostal space where the ascending aorta is. So you're going to hear an aortic stenosis, a systolic murmur of aortic stenosis. You'll hear it in the same location as you hear a normal S2 for the aortic valve, which is the right second intercostal space. On the other hand, if the aortic valve was incompetent and you had aortic regurgitation, that means that when the aortic valve should be closed, which means during diastole, it won't close fully, so you will get backflow from the ascending aorta back to the left ventricle. Well, we already know that the left ventricle is here. Again, we would go to the lowest part of the left ventricle, which is at the apex. So you would hear a diastolic murmur of aortic insufficiency at the apex of the heart. Okay? So all we're doing is following the direction of blood flow through the valve. In a stenotic valve, the direction is orthograde. In an incompetent valve, the direction is retrograde. We'll do just one more and then move on. The mitral valve, another commonly diseased valve. If you have mitral stenosis, that means when the valve is open, that means during diastole, blood will be turbulent passing through it. And since the blood is flowing to the left ventricle, again, you would hear the murmur best here where the left ventricle is, and you would hear that as a diastolic murmur because that's when the valve is open. If the valve was incompetent and you had a mitral regurgitation, the blood will flow through that valve in a retrograde direction during systole, and it will be flowing from the left ventricle to the left atrium. Now we know that the left atrium is primarily on the posterior wall of the chest, but that's pretty far away from where you can get your stethoscope. But you can get close to the left atrium by going into the left axilla. If you remember that the upper left border of the heart is the left atrium. So if you go into about the third intercostal space in the axilla, you'll be able to hear the regurgitation of a mitral insufficiency as a systolic murmur. So we're going to stop this at this point because the general principle is really what matters. This is not the sort of thing that you can memorize every conceivable kind of murmur. If you understand the principle of simply following the direction of blood flow and put your stethoscope over the region to which the blood flows, whether it be orthograde or retrograde, that's where you'll hear the murmur. The exact same principle applies to all of these. So we can turn our attention now to some other adult heart issues that we have not yet addressed. And let's start off by talking about the pericardium. Now, we don't need to spend a lot of time talking about the pericardium because our earlier discussion of the pleura basically told us much of what we needed to know, because recall that the pleural cavity and the pericardial cavity, as well as the peritoneal cavity, are all derived from the same structure, that is the coelom. And so we can say, just as we did before, now we can say the pericardial cavity is from the coelom. The two surfaces that encompass the coelom, the two layers of mesoderm, is what gives us the two layers of pericardium, just like it did pleura. So the layer on the surface of the heart, fused to the surface of the heart, is called the visceral pericardium. We'll often hear that also referred to as the epicardium. And the outer layer of serous pericardium is called the parietal pericardium, and the cavity in between is the pericardial cavity. And again, just as was true for the lungs, recognize that the pericardial cavity surrounds the heart. The heart is not in the cavity, but rather the cavity surrounds the heart. The heart is separated from the cavity by the visceral pericardium. But the one important difference that we should address here that makes this different from the pleura is that we have a third layer of pericardium. In addition to the visceral layer and the parietal layer, we have a third outermost layer called the fibrous pericardium, which is a very tough, fibrous, collagenous layer. And that fibrous pericardium is fused with the parietal layer of the serous pericardium. And what's important about the fibrous pericardium is that it's fibrous and it's not elastic. It doesn't stretch. So that means that if you have a rapid accumulation of fluid in the pericardial cavity, often as a result of bleeding into the pericardial cavity, the fibrous pericardium cannot stretch to accommodate that increased volume. And so as the volume of fluid in the pericardial cavity increases, since the fibrous pericardium will not allow outward expansion, we'll get inward expansion of the cavity, which means we'll get compression of the heart. And that compression of the heart will interfere with filling of the ventricles during diastole, so we'll have an impediment to diastolic filling, which means our end diastolic volume will be reduced, which means our stroke volume will be reduced, which means our cardiac output will be reduced, blood pressure will be reduced. So that means we have truly an emergency. And so the pressure of the fluid in the pericardial cavity has to be relieved, and pericardiocentesis would be done to remove that fluid to allow expansion of the ventricles during diastole. Let's continue our discussion of the adult heart. We first will look at the interior of the atrium. We've already had a glimpse of this earlier when we discussed the formation of the atrial septum. But now, just to remind you, this posterior wall is the atrial septum. There's the fossa ovalis. The SVC comes in here, the IVC comes in here, and there's a third opening that we can see here called the coronary sinus. We'll talk about that in a little while. Here we see the tricuspid valve leading to the right ventricle. When we look at the interior wall of the right atrium, we see that part of it has a roughened or trabeculated surface. Those ridges of muscle are given the name pectinate muscles, and part of the wall is smooth. The smooth part of the wall, all of this, is called the sinus venarum. Of course, that's derived from the sinus venosus. The trabeculated region is derived from the original primitive atrium. There is a ridge that separates the rough-walled from the smooth-walled portion. It's called the crista terminalis, and what that is simply the boundary between the primitive atrium and the sinus venosus, and therefore it's now serving as the boundary between the rough-walled and the smooth-walled portion of the right atrium. When we look into the ventricles, again we see rough-walled parts and smooth-walled parts. Again, we know that the rough-walled parts are from the primitive ventricle. The smooth-walled parts are from the bulbus cordis, which was the incorporated proximal portion of the outflow vessel. We see that some of these roughened trabeculae of ventricular muscle are actually much more elaborate than that, and they project right into the cavity of the ventricle, and those inwardly projecting muscles are called papillary muscles. So the function of the papillary muscles and the chordae tendineae collectively is to control the closure of the cusps of the tricuspid and mitral valves, to allow those cusps to approximate sufficiently to close the orifice, to close the canal, but not to go so far as to prolapse and thereby, again, open the valve. So those are the major elements of the interior of the ventricle. Let's now take a look at the arterial supply to the heart. And the blood supply to the heart is coming typically from two arteries, the two coronary arteries. They are both branches of the ascending aorta. They are the only branches of the ascending aorta. The right coronary artery leaves the right side of the ascending aorta, and it immediately enters the coronary sulcus. That's why it's called coronary artery, because it's in the coronary sulcus. Remember that the coronary sulcus is also the atrioventricular sulcus, so that means that this artery is sitting right between the right atrium and the right ventricle, and therefore it is supplying the right atrium and right ventricle. We can generalize that concept and simply say that all of the branches of the coronary system of vessels simply supply their immediately surrounding neighborhood. So if you know where the vessel is, you know what it supplies. So because the right coronary is sitting between the right atrium and right ventricle, it supplies the right atrium and right ventricle. And recall that the coronary sulcus continues around the back of the heart, and so the right coronary just stays right with it, continuing around the back of the heart between the right atrium and right ventricle. A branch comes off of the right coronary on the back of the heart and enters the interventricular sulcus, and that's called the posterior interventricular artery, or sometimes called the posterior descending artery. But interventricular tells us that it is between the two ventricles, and so it supplies the two ventricles and the posterior part of the septum. There's another branch of the right coronary called the marginal artery that simply goes out onto the right ventricle. The other coronary artery, the left coronary artery, comes off the left side of the ascending aorta, and it's really quite different because it's not a long artery like the right coronary is. It's a quite short artery. It's only about 1 inch long. It's just long enough to get past the pulmonary trunk, and as soon as it does that, it ends by dividing into two branches. One branch is the circumflex branch of the left coronary, and that's the artery that enters the coronary sulcus on the left side. And so again, it's sitting in the coronary sulcus between left atrium and left ventricle. Therefore, we know that the circumflex artery is supplying the left atrium and the left ventricle. But notice that because the circumflex is in the coronary sulcus, we've already said that the right coronary is in the coronary sulcus. Those two arteries are sort of coming at each other from opposite directions. And so we can imagine that in this region there are branches that anastomose with one another. And so the anastomosis between the circumflex branch and the right coronary is important because that means it's an anastomosis between the left coronary and the right coronary artery. So that if we were to have a partial occlusion, let us say, of the right coronary artery, the area distributed to by the right coronary can be supplied by way of that anastomosis from the left coronary. The other branch of the left coronary is the anterior interventricular artery, also called the left anterior descending, or LAD, and that enters the interventricular sulcus on the front of the heart, sitting between the two ventricles. So again, it supplies the two ventricles, left and right ventricle, and the anterior part of the septum. Since we have the LAD in the interventricular sulcus and we have the posterior interventricular in the interventricular sulcus, again, they come at each other end to end. Branches anastomose in this region. So again, we have an anastomosis between a branch of the right coronary and a branch of the left coronary. So the same principles apply as we discussed before. The only other elements of the coronary circulation that I wanted to comment on is to make note of the fact that the two nodes, the SA node and the AV node, which we will be discussing shortly, both usually get their blood supply from branches of the right coronary. There's a nodal artery that comes off about here to supply the SA node in this region, and there's an AV branch that comes off about here to supply the AV node, also a branch of the right coronary. Now, if the heart has an arterial supply, it must have a venous drainage as well, and we can see that on this diagram. And the individual veins, which are called cardiac veins, I don't think are of great importance to spend time on. But the one point that I want to make is that most of the veins of the heart, most of the cardiac veins, end up draining into one large vein. And that large vein is called the coronary sinus. So the coronary sinus is simply a big vein that receives drainage from multiple other cardiac veins. And then that coronary sinus drains directly into the right atrium. So as I said earlier, the right atrium receives not only the inferior vena cava and the superior vena cava, it also receives the coronary sinus with the venous return from the heart itself. Now we'll turn our attention to the cardiac conduction system. And before we discuss the cardiac conduction system, it's important for us to understand a few basic concepts about cardiac muscle and what makes cardiac muscle different from skeletal muscle. There are many similarities between the two, with the important similarities being that we have membranes that are polarized. When those membranes depolarize, it results in a series of chemical changes, including some calcium flux. The change in calcium results in some binding to some of the contractile proteins, which subsequently results in a sliding of the thick and thin filaments and the generation of tension. That's going to be true regardless of whether it's cardiac or skeletal muscle. But two important differences are the following. Skeletal muscle has a polarized membrane that stays polarized unless something is done to depolarize the membrane. And when that happens, then as a result of that depolarization, there'll be contraction. Typically, what causes the depolarization is a firing of the somatic motor nerve that goes to that muscle, releasing acetylcholine, which binds to membrane receptors, which then sets off this sequence of events. But if you don't do that, in other words, for example, if you were to cut the nerve going to a skeletal muscle, the muscle will not contract, because if it doesn't depolarize, it will not contract. On the other hand, cardiac muscle has a polarized membrane that spontaneously depolarizes, and then repolarizes, and then depolarizes, and then repolarizes. And every time it depolarizes, it contracts. So you don't have to do anything to it. You don't have to stimulate it with any external source. It will spontaneously depolarize, and therefore it spontaneously contracts. So that's one important difference. The other important difference is that skeletal muscle cells are electrically isolated from their neighbors. When one skeletal muscle cell depolarizes, the cells immediately adjacent to it are not affected because there's no electrical communication between the muscle cells. So the cell that depolarizes contracts, the adjacent cells do not respond. In cardiac muscle, the cell membranes do communicate with one another. They are electrically continuous. There are specializations called gap junctions that are found primarily at the intercalated discs, which means that when one cardiac muscle cell depolarizes, the adjoining cardiac muscle cells will also depolarize. So that's another important difference. So when we put those two thoughts together, that cardiac muscle cells spontaneously depolarize and they electrically communicate with one another, let's think about what that means. Even though all these cardiac muscle cells are spontaneously depolarizing, they don't spontaneously depolarize at the same rate. They're each individual cells, and they each have their own individual rate at which they depolarize. They're approximately the same rate, but one cell may depolarize at 40 times a minute, another one at 42 times a minute, another one at 38 times a minute. So they each have their own rate of depolarization. On the other hand, because they're electrically communicating with one another, When any one of them depolarizes, they all depolarize. So we need to think about what's going to control the rate of depolarization. And the answer to that is whichever cell depolarizes the fastest will force all the others to depolarize at that rate. So in the heart, there are a group of specialized cardiac muscle cells. They are found in the structure known as the sinoatrial node, which is found in the wall of the right atrium, right next to where the superior vena cava enters the right atrium. And these cells of the sinoatrial node are specialized cardiac muscle cells. What makes them special is they depolarize much faster than other cardiac muscle cells. So while other cardiac muscle cells may spontaneously depolarize at 35, 40, 45 times a minute, the SA nodal cells depolarize spontaneously at, let's say, 65, 70 times a minute. And therefore, the SA node drives all of the other cells to depolarize at its rate, and therefore we call the SA node the pacemaker. That's true, but only partially true, because while it's true that all of the atrial cells are electrically communicating with one another, and all of the ventricular cells are electrically communicating with one another, atrial cells and ventricular cells do not directly communicate with one another because there is a layer of what we can think of as insulation separating the atria from the ventricle. It's made up of fibrous connective tissue. It's called the fibrous skeleton of the heart, and it serves fundamentally as an electrical insulator. Of course, it's fibrous tissue, it's very few cells, few membranes, so we don't have electrical conduction. So that means, if that's the way this is built, that means the SA node can drive the atrial cells to depolarize at its rate, but it would mean that the ventricular cells would not know about that, and they would be depolarizing at an entirely separate rate, slower than the atrial cells. So to allow the ventricles to be electrically communicating with the atria, what we have is a defect in this fibrous skeleton, such like this. It's as if we had a hole in the layer of insulation, and passing through that gap, or passing through that defect, we have a bundle of specialized muscle cell that's known as the bundle of His, or frequently referred to as the common bundle or the common AV bundle or just the AV bundle. But it's these muscle cells that are communicating, they're running from the atrial septum into the ventricular septum by passing through that gap in the fibrous skeleton. And as a result of that, we now have electrical continuity to the ventricles. So now the SA node is not only driving the atrial cells, it's also driving the ventricular cells by way of the AV bundle and its branches, called the right and left bundle branches, which then spread out to all of the ventricular muscle. But we still need to modify this one more time, because if this is where the story ended, not only would we have the ventricular muscle depolarizing at the same rate as the atrial muscle, they'd also be depolarizing at the same time as the atrial muscle, so that atrial systole and ventricular systole would be simultaneous, which would mean that the ventricles would not have time to fill before they contracted. So what we want is that we want the ventricular cells to depolarize at the same rate as the atrial cells, but not at the same time. We want there to be a lag time between them. And the way we accomplish that is by having this bundle of specialized cardiac muscle called the atrioventricular node, the AV node, in the wall of the right atrium at the atrial end of this AV bundle. And it's constructed in such a way so that the only electrical pathway into the AV bundle is through the AV node. The job of the AV node is to slow down the velocity of propagation. In other words, the depolarization passes through the AV node more slowly than it passes through any other cardiac muscle. And so that retardation of the depolarization, the slowing down of the depolarization, results in the depolarization that has spread from the SA node, spread quickly through all of the atrial cells, gets to the AV node, And as it slowly passes through the AV node to get to the AV bundle, by the time it gets to the AV bundle and therefore into the ventricle, it's a little bit later than when it has spread to all of the atrial cells. So the AV node imposes that retardation, which allows the ventricles to depolarize at the same rate as the atria, but not at the same time, a little bit later. And so when we look at how that correlates with the typical electrocardiogram, we know that the P wave represents the atrial depolarization. The QRS complex represents the ventricular depolarization. So this gap in time between the P wave and the R wave, what's called the PR interval, represents the delay that was imposed by the AV node. So the more that the AV node slows down the propagation of that impulse, the longer the PR interval will be. The less it slows it down, the shorter the PR interval will be. So what we're saying is that the SA node it's the pacemaker, so it controls the number of times per minute that we have this series of depolarizations. And the AV node controls the lag time between atrial depolarization and ventricular polarization, which on the EKG is the PR interval. So it's noteworthy that in this discussion of the cardiac conduction system, we did not discuss nerves. We did not use the word nerve. In other words, everything that we've talked about in the cardiac conduction system is actually cardiac muscle, specialized cardiac muscle. The SA node, the AV bundle, the bundle branches, all of that is specialized cardiac muscle, which is to say that the cardiac cycle will function without any innervation. We don't need to have the heart innervated in order to have a cardiac cycle because the SA node and the AV node will do that itself. Now, that does not mean that the heart doesn't receive innervation. It, in fact, receives a very robust innervation. It receives sympathetic innervation, it receives parasympathetic innervation, and it has sensory innervation. So what's all that innervation for? Well, the motor innervation, sympathetic and parasympathetic innervation, does not cause the cardiac cycle, but rather it modulates the cardiac cycle. So although the SA node will depolarize at its own inherent rate and set the pace for the heart, if we want the SA node to depolarize more rapidly, sympathetics will tell it to speed up. If we want it to depolarize less frequently, parasympathetics will tell it to slow down. So we can control the heart rate with our sympathetic and parasympathetic innervation. Similarly, the AV node can be told to retard more or less the propagation of the impulse. So sympathetic innervation will shorten the PR interval, parasympathetic innervation will lengthen the PR interval. And similarly, sympathetics and parasympathetics will control things relating to the myocardial wall itself in terms of force of contraction and other things. So that the sympathetic and parasympathetic innervation modulates the cardiac cycle, but does not cause it. The sensory innervation serves a couple of purposes, and there are two different kinds of sensory innervation. There's the sensory innervation that reaches the heart by way of the vagus nerve. Just as the vagus nerve brings parasympathetic supply to the heart, it also carries sensory return from the heart going up to the medulla and pons. And it's through those sensory fibers that we can control the cardiac reflexes. So that since we already know that we can control the SA node and we can control the AV node, if we want our brainstem to do that, we have to have a feedback loop back to the brainstem as the afferent limb of these reflexes. And so it's the sensory fibers that travel with the vagus that accomplish that. That sensory information going through the vagus does not reach conscious levels. That goes up to the brainstem, to the cardiovascular control centers of the reticular formation, and that's as far as it goes. There are other sensory fibers that get to the heart by traveling with the sympathetic innervation, which means that it's coming from the spinal cord, since that's where sympathetics come from. So while we have these sympathetics bringing sympathetic innervation to the heart, there are sensory fibers traveling back to the spinal cord along with those fibers. And those sensory fibers, after they enter the spinal cord, will then contribute to ascending pathways that in fact will go all the way up and eventually reach cortical levels after going through the thalamus. So that means that that does reach conscious levels. And that means that there will be conscious sensation associated with that innervation. And what that innervation is doing is providing a method of monitoring the myocardium to ascertain whether the amount of oxygen being supplied to the myocardium is sufficient to support the amount of work being demanded from the myocardium, which is to say it's monitoring the myocardium for ischemia. So if the myocardium is becoming ischemic, there will be a sensory message that lets us know that reaches conscious levels. And we interpret that conscious sensation as angina. So that conscious sense of pressure or pain or discomfort in the retrosternal region or radiating into the left upper limb is being carried by way of those sensory fibers that are traveling with the sympathetics, which explains why when you have sensory neuropathies, such as those associated with chronic diabetes mellitus, we can lose that sensory information. And so while people with diabetes may be at higher risk of myocardial ischemia because of the small vessel disease, they at the same time may not have angina. And we call that silent ischemia because the sensory nerve fibers that should be carrying that sensory innervation back to the central nervous system are not functioning. Similarly, a person who has a transplanted heart in his or her chest, because that transplanted heart is a denervated heart, obviously the nerves didn't come with the heart, then that person who's the recipient of a transplant will not have those sensory fibers and therefore similarly could not have angina.